Welcome to the PTUB Pod, an educational podcast created by paediatric trainees in the Southwest.
Featuring reviews of journal articles and interviews with authors and specialists.
Please note, these are our own opinions and do not substitute professional medical advice.
Thanks for listening.
Hello and welcome to the PTUB Pod. My name is Felicity and I'm a paediatric trainee in the Severn Deanery. Today we're going to be talking about adverse childhood experiences and child development. We are recording in a busy hospital setting and therefore there might be some extra background noises today. I'm very pleased to welcome Dr Kate McCann. Kate is a community child health consultant and she is a member of the Trauma Informed Strategy Group in Somerset. She is a strong advocate for vulnerable children and speaks with particular passion about young people who have experienced childhood trauma. I read a quote from Kate recently, who said that community paediatrics is a continually changing area of children's health and an incredibly interesting and diverse field to work in. She went on to say that it is the resilience of my patients and their parents that always remind me of what the NHS really means to me. Every day, I'm humbled and inspired by the ways in which these families cope with adversity supported by the NHS. Dr. Kate McCann, thank you for joining me.
Thank you, Felicity.
Could you tell us a little bit more about yourself?
Well, as you said, I'm a community paediatrician. I actually grew up here in Somerset, went to school here, and then went off to Birmingham to study paediatrics, returning with my husband, who's a GP. I developed my interest for community child health while I was in Birmingham because I was fascinated by the variety that it brings. I'm really interested in understanding families, understanding the way they work and the relationships, but also having the chance to see children develop over time and to be part of their lives and part of their journey.
Oh, thank you. Today we're talking about adverse childhood experiences, often shortened to ACEs, and how they can impact a child's development. Now, often we choose an article to discuss, but we're doing something slightly different today, and I based my questions on a TED Talk. The TED Talk, for those listening, is by Nadine Burke Harris, and it's called How Childhood Trauma Affects Health Across a Lifetime, and I'll provide a link to that in the show notes.
Yes, I'm particularly passionate about that TED Talk, as it probably was my gateway into the world of adverse childhood experiences. I probably got first of all interested after a colleague called Dr Sarah Temple, who is a GP in the local area, came to talk to us in the department. I was a registrar and then an acting consultant at the time. I noticed a real pattern. I'd seen our referrals increase hugely over recent years, probably by 100%. And these weren't always children with neurodisability, with development problems, children that I needed to investigate. They were children with behaviour problems, parents in desperate need, parents really worrying about their children. And it was this chance talk by Dr. Sarah Temple who came to talk to us about emotion coaching. And it seemed a bit bizarre that I was suddenly learning about emotional development at the late old stage of paediatric training. But I was fascinated by the fact that really until then I hadn't considered so much childhood attachment, the way children develop in terms of their brain, their relationships and their emotions and learning in general, and how that related to the experiences they were having. Dr. Temple introduced me to adverse childhood experiences and Nadine Burke Harris. And this TED Talk I would encourage everyone to see because she really talks about the passion of adversity in childhood and how this affects our physical and our psychological health over a lifetime. And it has led me on to be able to talk about adversity in clinic, to be able to see patterns in the children I'm looking after, and for us to think about the children we're seeing through a trauma lens and helping their parents and their families to see that rather than labelling and sometimes mislabelling with conditions or limiting their opportunities rather than providing a chance for them to recognise what's happened and to learn to repair and heal.
You really beautifully covered why you think it's such an important topic. Starting at the beginning, what do you think is meant by adverse childhood experiences when we're talking about them? And what's meant by childhood trauma? Because I've noticed the terms are often used interchangeably.
Yes, I think it's really important to say that actually I think these terms can be used interchangeably. So whether we're talking about neurodevelopmental trauma, childhood trauma, adversity in childhood, ACEs, it's really difficult to pick between them. But I suppose adverse childhood experiences are these highly stressful events or situations that happen in childhood and or adolescence. They can be single events or prolonged threats and essentially breaches to a young person's safety, security, trust or bodily integrity. Now that's a definition from the British Psychological Society, but the key bottom line is this, that ACEs are significant traumatic events that occur in childhood and basically have long-lasting negative impacts on psychological and mental health. The reason they're important is because they can result in poor health and shorter lives. And these experiences are the facts, they are what happens. But for me, the trauma is what that does to the person. So the childhood trauma, neurodevelopmental trauma, that is how it is then played out in the body. The effect it has on the bodily systems. So whether that is the brain, whether it's the effect on the DNA, on the stress systems of the body, it is what plays out in that person. The effects are not inevitable, and that we actually can help people to repair and heal from their trauma, but that requires people recognizing it in the first place. Because my feeling is, and I've used this quote before, that trauma is one of the most misunderstood and belittled experiences that a human can endure. And if we don't recognize it, if we don't understand it, and if we don't help our families to recognize it, because it is often intergenerational, we can talk about that, it's actually, we miss those opportunities for them to make changes in their lives and start to be able to repair.
Yeah, I read a quote by a psychiatrist, Professor Bessel van der Kolk, who wrote the book The Body Keeps the Score.
It's a great book.
Yeah, and they said, we've learned that trauma is not just an event that took place sometime in the past. It is also the imprint left by that experience on mind, brain and body. This imprint has ongoing consequences for how the human organism manages to survive in the present. Trauma results in a fundamental reorganisation of the way mind and brain manage perceptions. It changes not only how we think and what we think about, but also our very capacity to think. So Nadine Burke Harris discusses the Adverse Childhood Experiences study, which I'll link to in the show notes. Can you tell us more about that study and some of the evidence behind the Adverse Childhood Experiences research?
So, the original Adverse Childhood Experiences study was set in the 90s in America and in an adult obesity clinic. So you might think that that isn't relevant to our population, but actually what it has told us is a huge amount of information essentially about the biochemical coping mechanisms that people use to escape the stress, anxiety and fear that adversity in childhood causes. So it was around 17,000 patients in an adult obesity clinic, and it came about due to the fact that these adults on the weight loss program would do well. They'd be losing weight, being successful, and then they'd start to drop out. And it was a chance discussion with a patient that Dr. Felitti observed those patients who struggled, those ones who dropped out or that struggled with that weight loss, had faced some sort of childhood adversity. Essentially, food had become a solution to their problem. They were using comfort eating, a real term, because it was soothing their anxiety, fear or depression. A bit like, drugs, alcohol, smoking do. And it's difficult to get people to stop doing that when it's providing a gratifying solution to their brain wiring issue.
Yeah.
So Felitti then worked with Anda, who is an epidemiologist, to devise a questionnaire to then score people on these adversities. And they looked at these 10 original ACEs. You can go anywhere and find out. That's looking at physical, emotional, sexual abuse, physical and emotional neglect. And then these very American term, but household dysfunctions. So that's mental illness of a parent in prison, domestic violence, substance abuse, and divorce as one of those adversities. And we need to expand it further to consider community violence, warfare. And we can't really judge an adversity in life to be non-traumatic unless we've experienced it ourselves. So I'm not saying that everything is a trauma, but we need to consider looking through a trauma lens at what people have experienced. So they devised this questionnaire with the 10 original ACEs and went through patients, scoring them if they'd experienced each type of adversity. So, for example, if you'd experienced emotional abuse, lived with a father who had mental health illness and a mother who had alcohol dependence, the score would be 3. And what they found was that having an ACE was really common. More than half the adults in the study had experienced one or more type of adverse childhood experience, and 13% had 4 or more ACEs. And so studies all over the world have replicated that similar finding. Importantly, adverse experiences happen across the population, not just as previously might have been thought within areas of deprivation. These participants were 70% white, 70% college educated. It is also important to point out that there was a direct link between childhood adversity and adult disease. So this is heart disease, cancer, chronic lung disease, as well as mental illness. And I think the last, probably most important point to mention was that there was a strong graded relationship between the breadth of exposure to adversity in childhood and multiple risk factors for several of the leading causes of death. In other words, the more ACEs a person had, the higher the impact across the lifespan on their mental health and well-being. So there was this dose-responsive effect. The impact of ACEs on health had a greater impact than just lifestyle choices alone. So, for example, smoking, drinking, lack of exercise. Those people with a higher number of ACEs were still more likely to develop health difficulties than those without ACEs or lower number of ACEs who made poorer lifestyle choices. So this concludes, effectively, that ACEs are in themselves a risk factor and need to be considered that alone.
Yeah, and you touched on this earlier, but how can exposure to adversity affect the developing brains of children?
So we know that the crucial time for brain development is from conception to 3 years of age, particularly for motion and behaviour. We talk about the first 5 years being absolutely crucial, but those 3 years are particularly important. Brains are built from the bottom up. So our sensory pathways, hearing and vision, are the first to develop, then early language skills, then higher cognitive functions, and connections proliferate and then prune in a prescribed order. So later, more complex brain circuits are built on those earlier simple circuits. So we need that strong foundation, that core, to be secure so that we can develop those higher cognitive functions. And those higher cognitive functions are learning, memory, but also things like emotional regulation. Toxic stress damages that developing brain architecture. So what I mean by toxic stress, people will have heard this used, and I think toxic is a really overused term at the moment. I hear it used a lot, but toxic stress is absolutely vital. So positive stress is probably how I'm feeling right now. You know, I have a bit of a high heart rate, feeling a little bit sweaty, Flick's putting me under pressure. No, not at all. But that's positive. You know, we need that in exam situations. We might need that to win a race. Tolerable stress, you know, that's stressful situations that activate our systems to a greater degree. So that might be something we see in natural disaster or death of a close relative. These responses, again, are okay if they are buffered by good relationships with others. Toxic stress is about the prolonged activation of our stress systems due to significant adversity, due to these adverse experiences. And this is largely due to the effects of the hormone cortisol staying persistently raised in the body. The way that trauma affects the body is actually often life-saving. So Nadine Burke Harris uses this great analogy that I absolutely love when she talks about a bear in the woods. That idea that if we're walking through the woods now, or we're sitting in this room now, and a bear comes in, our flight or fright response is going to kick in. We are going to have cortisol and adrenaline rushing around our body to help us probably not fight the bear, but hopefully run away. But what happens when the bear is there all the time? When it's coming home every night and your cortisol and adrenaline is running around the body, but it's got nowhere to go. And instead of being life-saving, it becomes life-harming because it becomes a maladaptive mechanism.
Yeah.
You're not using that flight or fright in the right way. And this is what I am seeing every day in clinic. I see children who are in flight or fright responses, and that is related to what they are experiencing at home. And I'm not saying that that isn't all they're experiencing. A lot of the children I see also might have genetic conditions. They might have neurodiversity, autism, ADHD as a background. But then the key is that trauma is experienced by them even more sensitively. And that's really important for families to understand too. So if people want to read more, the BMJ paper from 2020 that was written by Nadine Burke Harris and colleagues, Adversity in Childhood is Linked to Physical and Mental Health Throughout Life, is a good paper to read. And there's a lovely infographic on there that shows the pathways that mediate exposure to early adversity and the adult outcomes. This is all about cell level effects of the prolonged stress response and how it's affected on the body. So the reduction in volume of key brain areas, damage to neurons, fewer, more brittle connections. And you can go back to looking at the functional MRI studies of temporal lobes in Romanian orphans and those children that were severely neglected. We can see that evidence early on. We also talk about epigenetic changes. So shortening of telomeres, changing the expression of DNA, the acceleration of cell aging, and greater risk of immune regulatory systems. So increased risk of infections, later in life, that predisposing to chronic diseases. It all goes back to how the brain is built and that early childhood attachment, what you experience, and it shapes your whole brain development. Our brain is built through serve and return interactions. And that is really important for the way a child develops. Do you know what I mean by a serve and return interaction?
Yeah, I recently looked at the Bucharest Early Intervention Project, which you touched on before. And on their website of this trial, they've got a really lovely video about some of the early experiments of serve and return, like what happens with a mum if she goes into a room and rather than responding normally, she suddenly has a blank face, and that child's stress response to the fact that their mother isn't responding to them as normal.
Yeah, the still face experiment was some of that early work that absolutely shows the importance of communication and interaction between young children and their caregivers. And it's worth, having a look just at that. It can be quite upsetting actually to see the child's response and the way they get quite stressed. One of the most important things a parent can do is serve and return through play. So this is like a tennis match, okay? Think of it in this way. You notice the serve and they share the child's focus of attention. They return the serve by supporting, encouraging. So, yes, that's a red car. Look at the car. You give it a name, take turns and wait and keep the interaction going back and forth. And the reason it's important to talk about serve and return is because it's the key, the foundation to healthy relationships. If children aren't experiencing this two-way relationship and interaction, then they will not have the chance for their brain to develop in a typical way to develop emotional regulation. And there's some really good videos and explanations of this on the Center of the Developing Child at Harvard University. And there's a really lovely TED talk by Molly Wright, who's just a 7-year-old girl. She is talking about neuroscience in a way that is so relatable and so understandable that I think every parent should see this video. Every parent should understand that it is simple play, interaction and love that they need to give their child a healthy brain development. But when I'm saying that quite simply. How can parents do that when they are experiencing adversity? How can we support parents to know that this very simple serve and return interaction is so crucial for their child's development, no matter what their genes are, it is crucial for every child to experience so that we can give them that really good early foundation. I do at times find it difficult to start talking about attachment in clinic because it can be quite challenging. It might imply that it's a one-way process and parents feel blamed for their child's difficulties with their behaviour, but it's a two-way reinforcing process. It is hugely related to environments and social situations. And the key is that it's about parental sensitivity, parental availability, but also child availability, child sensitivity, parental experiences of being parented themselves, attunement, and the environment around that is absolutely crucial.
Yeah, and you mentioned that it's intergenerational, and I know that's a key concept of the life course perspective. The health and socioeconomic status of one generation can directly impact the next generation. How do you tend to see that play out in clinic?
I see it really commonly, actually, and it can be difficult to talk about. But actually, we are doctors and we need to have difficult conversations with patients and their families. And so I am quite open at the beginning. One of the ways I often approach this is to say to a family, I'm really interested in the behaviours a child is showing. And sometimes I see these sorts of behaviours when there's been difficulties within the family. Can we talk about that a little bit more? I'm often amazed by how open mothers can be in particular, but also I see fathers, I see grandparents, and helping them to understand and then talk about some of the traumas they might have experienced or might have experienced in their family, and then to see how the abuse they might have suffered from their father, why their father might have perpetrated that, why they have then gone on to parent in a different way, because actually it's all the experiences we have as well as our genetics that lead us to parent our own children. That helps them to understand how that might have then gone on through generations. And the key is breaking the cycle.
You mentioned about behaviours. What kind of behaviours might we be seeing?
So I think it's really hard to unpick, because I think we have a tendency now to look for diagnoses and look for labels. When I first started being interested in this area, I was seeing everyone referred in as autism or ADHD. And some of those children I saw will have had autism or ADHD, but some of them didn't. And the behaviours could be confused quite easily. So, for example, I could talk about a young person who came to see us with concerns about anger, throwing chairs around the classroom, getting very frustrated with his friends, and they were wondering about ADHD. He'd experienced huge domestic violence at home. He was scared and terrified. And we talked before about that flight or fright response when the bear is present. That is exactly the sort of behaviours he was displaying. What we're looking here is, what does trauma look like? And the point is, people don't walk around with trauma as a label, and we don't want it to become like a new label fashion. It needs to just be something that we're all aware of, that we're able to recognise and respond to. So it might be the child that's really showing distressed signs in school. It might be the child that is overquiet and struggling to communicate. The important thing is that we need to be able to recognise signs and symptoms, as we might do with any other condition, and be able to ask about it. We're not trying to label these children, but we're trying to see them through a trauma lens. So understanding that every behaviour is a communication, but what is behind that behaviour that is challenging us? We often might hear words used like, oh, she's an absconder for the child, that keeps running off the ward, or she's an attention seeker. He's just difficult, or he's aggressive. All these words and the language we use actually is describing a child underneath, and we need to reframe that language and think about what that child is trying to tell us and what is going on underneath. There might not always be trauma. There might not always be difficult experiences, but unless we consider it, unless we think about it really in every presentation that we go to, then we will miss it, and we won't have that opportunity to recognise and be able to repair and form relationships.
So some have raised that children who have experienced early trauma and adverse childhood experiences can present with differences in their development, and there can be overlap in how they can present with children who are neurodivergent. And we know those conditions can coexist and that relationship isn't well understood. How do you approach that when you're completing assessments, when you have a child who has a strong history of early adverse childhood experiences and actually looking at them in the clinic when you go, actually they have features of autism?
I think it can be really difficult to unpick, and that's why here in Somerset we now have a huge multidisciplinary team looking at neurodiversity that involves psychologists, doctors, nurses, speech and language and occupational therapists. That's not very helpful for when you are just sitting in clinic looking at a young person, but I think it's being able to bring up the topic and recognise that whilst they can coexist, it's important that we recognise and address trauma, because actually, if we don't, we're just missing that opportunity to address that need. For example, a child might present as hyperactive, but actually is that hypervigilance related to the trauma they've experienced? They may be inattentive, but actually is that their memory of the experiences and the way that the trauma has affected how they lay down their memories, and their concentration is related to what's going on around them. What I'm saying is it can be difficult to unpick. And of course, you can experience both neurodiversity and trauma. And that's important to say that those people who are neurodivergent may well experience trauma even more sensitively due to the wiring of their brain. But actually, if we don't address the trauma, we miss that opportunity for understanding, for greater understanding.
Yeah, and in her talk, Nadine Burke Harris talks about the importance of prevention and treatment, as of you and that recognition. And she helped to create the Centre for Youth Wellness in her area with the goal of preventing, screening and healing the impacts of adverse childhood experiences, as she phrases it. Have you come across interventions or examples of emerging good practice in the UK? Because I think most of the families that I've met, as you said, who have been really open about their experiences, actually most parents I meet are just really keen for help and support. They can recognise that some of the challenges they've been through, but actually some of these things are really hard to overcome. If a parent's struggling with their mental health, if they're struggling with poverty and that stress of actually how do I feed my children, that's hard. How can that be tackled?
That's the big question, Flick. Yeah, I think that is the absolute key. There is good news, because that's what Nadine is telling us, that it is never too late. It's never too late to start rewiring your stress response. You've got to recognise the problem is there in the first place. But how can we do that without a system that is trauma-informed and trauma-aware? It requires a whole system change. It requires us all to be trauma-informed. And I think of this as a pyramid. If we had everyone that was trauma-informed, the next stage of the pyramid would be those people who are trauma-skilled. And that would include doctors and nurses who are able to talk about some of these experiences and help families in to some extent. But the top of the pyramid would be the trauma-enhanced or trauma specialist, because if we are all trauma-informed and trauma-aware and we start recognising and supporting people, then only a small number of people would need trauma-enhanced or trauma specialist work, because actually they wouldn't be continually triggered and re-traumatised on a daily basis. Essentially, that requires a whole public health strategy. Robert Black, who was the president of the American Academy of Pediatrics, has said adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And that is because we need a widespread government strategy in order to be able to address adversity. Because as you said, how can we help parents to serve and return, interact with their child when they are experiencing poverty, they are experiencing homelessness, they're experiencing serious threat, ongoing domestic violence? We have to have a strategy that addresses all of this in a safe and sensible way, but that requires thinking. It requires governments to input and invest in early childhood, to invest in families, to be able to see the repercussions years down the line. Because if we do invest in reducing adverse childhood experiences, we have the opportunity to reduce the burden on mental health services, on physical health services, and that will in turn save us billions and billions. There are studies that have projected this cost savings are profound and significant, but that will mean investing in something that they won't be able to see the outcome of until many years later. And I think governments may find that hard.
Yeah, I spoke to Helen Leverett on an earlier podcast episode about childhood poverty, and that's a really interesting episode for anybody to go back and listen to, and she addresses some of those factors. Now, I know that there are some controversies around adverse childhood experiences and how the original research has gone on to be used. Do you mind telling me a little bit about that?
So there is a great concern that if we just start using ACEs as a checklist, it will become another meaningless tool. It will become quite labelling and stigmatising, and it won't have any actual outcomes for our patients. And I think we have to be wary of that it isn't used in that way.
Yeah, because I guess it was used as a research screening tool initially, and so the evidence to back it up at an individual level hasn't necessarily been shown.
Absolutely. We need to provide sympathetic responses and trauma-informed support by those who've been impacted by ACEs. It's crucial that we don't use ACEs just as another label or as another diagnosis. And there was a really good report in 2021 from Wales, their review of adverse childhood experiences policy, that said exactly that. It's a great review of how we need to move on from the original research of the ACEs study. Key being that the ACE score should not be used with individuals to determine risk or whether or not to offer an intervention or the type of intervention that should be offered. We need to avoid stigmatisation and actually be aware or be wary perhaps of using the term ACEs, mindful of its impact. We don't want ACEs to be deterministic. It's just got to be that we can use the understanding to recognise that adversity exists, support and promote community-based self-help, peer support approaches to prevent that adversity and mitigate its impact. As doctors, we need to be advocates for the children we're seeing in terms of how we can influence policy in our local areas and also nationally so that we can reduce childhood adversity and give families and children the opportunity to heal through developing relationships, but not just simply scoring children another tool that then just gives them another label. It's got to be more than that. And I think we do need more research in the area of the usefulness of ACEs screening, because I don't think it's completely useless, but we can't use it as a tool in its own right. And what Nadine Burke Harris does is, yes, she might well score children for ACEs, but she then has a team around her who are able to support that family. So whilst she's aware that a child has adverse childhood experiences, she alongside that treats their medical condition, but also has a psychologist with her. So I'm not saying that we need a psychologist in all of our clinics, but what I'm saying is that we need to be able to recognise those that need the understanding, those that need more skilled workers, and those that need the enhanced help. And we need to build services that are able to support those families with those needs.
Yeah. And you mentioned trauma-informed care earlier and emotion coaching. I think a situation that happens on the acute general paediatric ward is sometimes we have young people who have experienced significant trauma presenting with challenging behaviours on the acute paediatric ward, and that can include violence towards staff. That can be really hard for team members. Do you have any tips for managing those situations that can be quite emotive for everyone involved?
It's really tricky, and I'm aware of how challenging it has been recently for my general colleagues on the ward. Along with the increased behaviour referrals that we've seen in clinic and community child health, we've definitely seen the impact on the wards. And I think this is where it's really important to change and reframe. So we talked earlier about reframing our language. So rather than seeing a child as attention seeking, we're seeing them as seeking connection. Where rather than seeing them as aggressive, we're seeing them as distressed.
Yeah.
Those children are showing trauma responses. And when we think about what does trauma look like, it has very many guises and very different presentations. The key message here is that one or more responsive relationships can buffer the effect of ACEs, of adverse childhood experiences. And whilst that would be a member of the family, in some cases, it can just be the person on the ward, the receptionist in the GP surgery. What's really important here is that we all seek opportunities to create relationships that are meaningful and helpful. And that doesn't mean long-lasting relationships, but that we seek out developing trust, helping our patients have some element of control and empowerment in their own situation. We collaborate with them. And this is all the basis of trauma-informed care. Trauma-informed care is about recognizing how common trauma and adversity is, recognizing the way that different ways it can affect people, responding to it, and taking those opportunities to resist traumatization. Because in the environments we work in, re-traumatization is common, and this is commonly experienced by a lot of the young people we see, but also their families. And the more we can do to understand what is going on and to reduce conflict for those families and those patients, the more we can help build those relationships. And this is where we come back to something you mentioned earlier, emotion coaching. Emotion coaching is actually quite a simple way to understand someone's emotions, to recognize them, empathize, and be able to validate and give boundaries and support to be able to change behaviours. And we can do this in simple ways on the ward. Emotion coaching is what we see parents doing on a daily basis, but actually we can bring this into our lives with our colleagues, with the people we meet every day, particularly when we're seeing people in clinic or on the wards. And it's a really simple and easy tool to be able to connect with the young people we're seeing on a daily basis.
Yeah, I'm interested in doing an emotion coaching course, and partly I learned about it because another trainee was doing a procedure and they were struggling with it. And the consultant came over and said, "You look frustrated." And it was a really amazing communication to observe. And afterwards I was speaking to another colleague who said, "Oh, they were emotion coaching them. They emotion coached them through doing this neonatal procedure." Brilliant. And afterwards I thought, oh, that's such a life skill for everyone around you to be able to communicate in that way.
I love that you saw that. And I love that people are using this because it's not new. It's not something that's been invented. It's just that we forget about these things with social media, with the advent of diagnoses and to be honest, a tendency to medicalise. We are in a situation where at times we are over medicalising. Emotion coaching brings it back to the very, very basics of empathy, of human connection, of understanding. And it is fascinating to see how it works in practice. You've mentioned that example there. I've done recently a Tuning Into Teens course, and there's some brilliant examples in that of how just empathising with your teen rather than giving them ways to behave or telling them what to do actually builds that trust. Because that's the key to all relationships. Trust is at the very heart of it. And if you feel listened to, if you feel that someone is connecting with you and they understand, you don't have to give them the greatest advice in the world. It's just the fact that they feel heard. And again, that's what trauma comes down to. People feel hidden. They aren't being heard, and they've often had to cope with huge amounts of stress and worry such that their connections in their brain are already what we call flippy. And I use the hand model. You're going to laugh at me now. I am here with a I look like a little teapot, don't I? But if you look on Sarah Temple's emotion coaching, so if mindfulemotioncoaching.co.uk, she should have some of her videos there of the hand model. And this was coined by Dan Siegel, who's a great psychologist in all things to do with emotion coaching and emotional development. And if we brains that have been exposed to trauma and stress, their amygdala, which is my thumb curled in here, has a weaker connection with the sort of frontal cortex, which is obviously your thinking and your processing brain. And we describe their lid as being flippy. So if you're already in that state where your lid is a bit flippy, it doesn't take much for you to flip your lid. And by that, I mean, you really lose it. And those are the children we see in clinic, or the children on the ward, who might be swearing, they're exploding, they're behaving in a way that might be really unacceptable to us, but that's their response. That's how they've learned to cope with some of the situations they've been in. And by intervening early, by recognizing that, I can see you're looking upset right now. I can see you looking frustrated. I can see all those lovely words of being able to describe someone's emotions. We can immediately bring their flippy lid back down and help them to recover and emotionally regulate. Again, not by telling them what to do, but by empathizing and by validating their emotion. We're not telling them that the behavior is acceptable because, as I say to my 4-year-old nephew, all emotions are okay, but not all behaviors are.
That's such a nice phrase.
And we use that because actually that toddler emotion, that dysregulation when you've been told you cannot have a second chocolate bar, it's frustrating, it's disappointing. All those emotions are in this tiny little body. And actually what we need to do is be able to help them regulate that. And that's in toddlers, that's in our teens, that's in our colleagues, and that's in people who've faced traumatic experiences. And I don't want to simplify it by saying that all people who've experienced trauma just need emotion coaching, then they'll be fine. But these are the tools that we can use to help people in those situations of distress when they're in flight or fright, to help them start to regulate and feel heard and start to develop trust for the professionals around them.
That's really helpful, thank you. Are there any other resources that you'd recommend that you haven't already mentioned?
So certainly, along with Nadine's TED Talk, her book, The Deepest Well, is a very good read. It's interesting, it's amusing at times, and it's written at a level which I think people will be able to relate to. The Body Keeps the Score, you mentioned, by Bessel van der Kolk, excellent book. A bit of a longer read, is really helpful in understanding how that toxic stress affects the body and the mind and how intrinsically they are linked. I am at the moment going through the modules on the Oxford Brain Story, and there are some really great videos here on serve and return, early brain architecture, and that can be useful for parents in clinic, I think, to help them understand a bit more. They're quite short videos.
I've not heard of those. What were they called then? The Oxford?
So the Oxford Brain Story.
Brain Story. Oh, okay. Are they freely available to everyone?
So it's actually, at the moment, it's still a free course that you can do. Okay. There's many, many modules. I mentioned the Centre on the Developing Child at Harvard. Some great videos there. Again, some great information on toxic stress and the way the brain is affected. And for families, I've often recommended the UK Trauma Council. There's some good videos on there that can help families understand the effect of adversity on the brain. And I've particularly found that those families who start to understand adversity, who start to understand the way it presents in their child, they've been able to make changes and break that intergenerational cycle. And some of the videos are quite relatable on that website, and it can be really empowering.
Thank you. So many of our listeners are paediatric trainees. If you could give them some advice, what would it be?
So I've already mentioned this quote in part, but this is by Peter Levine. Trauma is perhaps the most avoided, ignored, belittled, denied, misunderstood, an untreated cause of human suffering. We need to change this, and we can change this. It requires a culture change, a reframing of language, and a shift of understanding. But the first thing is to recognise it. And so my advice is this: for us to change our question, what is wrong with you, to what has happened to you, and to understand that we have an amazing opportunity where we are, our privileged position of supporting, helping, and empowering our patients to understand what has happened to them and to really appreciate that every interaction is an intervention.
That's so powerful. Thank you for sharing that. And my final question, which we ask everyone, do you have a book recommendation? It doesn't need to be medical.
So I have 2 book recommendations. These are both related to understanding childhood adversity and the power of healing and hope. So the first is Goodnight, Mr. Tom, which is the wonderful story of a boy who suffers significant childhood trauma due to his mother's mental health illness and comes to live with Mr. Tom in the war era. And it's a beautiful story of incredible emotion coaching, incredible relationship development and interaction and intervention, but from a whole community perspective, not just from Mr. Tom. And we see the way that this boy changes from a child who has significant problems at the beginning and how he develops over time. And my second recommendation would be The Secret Garden by Frances Hodgson Burnett. And this book is a brilliant study of, again, adversity in childhood and, again, the way we as adults might impart some of our behaviours on children, but how relationships, and again, the key in this is relationships between children, can support growth and mindset change, and just a lovely story of hope.
Thank you very much for sharing those. And thank you so much for joining me today. I hope everyone listening enjoyed this episode and found it as educational as I did.
Thank you.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the Peds Hub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch. Thanks for listening.